Today we have a very distinguished speaker, Professor Bhimma from South Africa. Professor Bhimma has been a regular speaker with us since the last few months. It's the third episode with us. Extremely grateful for giving us your time, Professor Bhimma. So Professor Bhimma was an undergraduate from Natal College of Medicine, South Africa, and did his M.Med in Pediatrics. And following that, did his ISN fellowship at the University of Toronto, and then a pediatric nephrology at South Africa, and a doctorate in medicine Ph.D. In pediatrics and child health. Professor Bhimma has has a number of professional affiliations, which is listed over almost 24, and a large number of awards for all the work that he's done, research work, hepatitis B, inflammatory markers, interferon alpha, nutrition, and he was given the International Man of the Year Award in 2003 by the International Biological Center, Cambridge, England in 2002, that is. Then the Medical Research Council Award, long-term outcomes of Indian children with steroid-sensitive nephrotic syndrome. So he's had this pediatric nephrology for a very long time, with a lot of publications, which are at least, I would say, almost 100 publications, presentations, and he's also a member of the Biomedical Research Ethics Committee of the university, chairperson, Faculty of Research Committee of the Nelson R. Mandela School of Medicine, and so on, a lot of positions. So with this, there is so much to say that I cannot enumerate everything. And with this, I hand over today's topic to Dr. Professor Bhimma, who will enlighten us on steroid-resistant nephrotic syndrome in children. Thank you, Dr. Bhimma, for coming on.
Thank you, Lloyd. Firstly, thank you very much for that lovely introduction. I think you went overboard. I heard been introduced previously, so I am not unknown to this audience. So what I'm going to do is start to share my screen. Now remember, when I am talking about steroid-resistant nephrotic syndrome, this is a pretty large area to cover. And I said in children and adolescents, and I understand that a lot of you are actually nephrologists who treat adult patients. So there's going to be some overlap, not completely, but I wanted to say adult nephrology, but I realize every one of us are adult nephrologists. So it just means those of us who treat adults. So there's going to be some overlap, but I tried to concentrate it more on the pediatric side because that's where my expertise lies. Now, having said that, remember, a lot of steroid-resistant nephrotic syndrome overlaps with things like focal segmental glomerulosclerosis, and this is not intended to be a lecture on FSGS, etc. And the topics I'm going to touch on, and I'll outline the lecture just now, are quite extensive, and each one of them is a talk on its own. So I once again put in a disclaimer that I'm just going to highlight some of the important issues in this topic and not try and give you an expose on every one of them. Okay. So let's just begin. So the outline of my talk is, I thought it'll be interesting just to cover the history of nephrotic syndrome in both adults and pediatrics, because it's one of the most common diseases that we see, okay? Then, of course, we have to define childhood nephrotic syndrome to know exactly how we define it in pediatrics, and maybe those who are treating adults can tell us what are the differences. And then, of course, we need to classify it just so that we know what we're talking about, and then to discuss a few definitions in pediatric nephrotic syndrome. I'll briefly touch on epidemiology. Pathogenesis, this is, once again, as I said, a talk on its own, so I'm just going to very briefly mention that, and then we'll discuss issues of management. And here too, it's a talk on its own, okay? So, as I said, a lot of it overlaps with various other fields of histopathological forms of nephrotic syndrome, so you can't do everything. And then I'll just briefly touch on the new biological, some of the complications that we see, and of course, then the conclusion. So that's going to be the outline of my talk for today. And I hope that we finish on time. Sorry, we are starting a bit late. Let's look at the history of nephrotic syndrome. So what can we say about nephrotic syndrome? Basically, it was described even before the birth of Christ. And it was described by the father of medicine, who is, of course, Hippocrates. And Hippocrates described it in 460 BC. And he was a Greek physician who lived during the Greek classical period. And for those of us who did history, you'll know that this was a very, very long time ago. And in that period, even then, he was eponymously known as the father of medicine. And even today, I'm sure all of us have to take the Hippocratic oath before we even begin to practice medicine. So at that stage, he had some idea about what this condition was. He referred to generalized edema by the term dropsy. And he made the observation that when there's bubbles that settle on the surface of the urine, this indicates a disease of the kidney, and that this disease tends to be protected. So there's two important things, observations he made. One was, well, actually three. Bubbles in the urine. Of course, we know that that's the telltale sign for excessive protein in the urine, okay? Whether that's based on a physiological basis, whether you're up in the mountains, or it's a very cold weather or something, or you get sick with the fever, you'll find that when you have excessive amount of protein in your urine, the urine becomes very bubbly, okay? That's because of the increased surface tension. And then the next observation he made was that this was possibly related to the kidneys, okay, even at that stage. And the third thing was that this disease was protected. So even then, he knew that this was a chronic condition in most cases. So this was dropsy, and it was characteristic of these patients who developed generalized edema. And here on the picture, you can see bilateral pitting edema of the extremities, which is very classic of this condition. Then it was around about the 1400s that there was a physician from Belgium, Cornelius Rollens, and he described this entity of dropsy, which is whole body swelling, basically as a condition where you develop what today we know as nephrotic syndrome, okay? And he had a very, very interesting treatment for this condition. He said that if you take the tops of elder plants, and the one on the left is the elder plant, that is on my left, so I'm sure it's yours as well. So this is the elder plant. Let me just see if I can get a pointer. Yeah, this. Yeah, okay. So this is the elder plant. And if you take the Danswort plant, and surprisingly enough, I was driving past from the hospital today, and just behind my house, there's a whole growth of these plants, okay? And he said, if you cook this in wine and wrap this child in a hot cloth and apply this poultice either in whole or part to his body, that cure him. So it was interesting that even then too, they had some type of therapeutic intervention for this condition. Of course, I'm not sure how well this worked, and I'm not going to try it, but it is something to make note of, that even in the 14th century, they had some idea of what this condition was and how it's going to work. So it was around about 100 years later when a Swiss physician by the name of Theodor Zwinger, who made the first accurate description of nephrotic syndrome. And he noted that you have decreased urine output, and he then attributed this. At that stage, they had some idea of what the kidney was about and what it looked like from the cadaver specimens, etc. So he thought that if you get this condition, there's some obstruction and compression of the tubules of the kidney, and therefore this resulted in this decreased output. And what he noted that in children, that because heart and liver disease really manifest, this condition had to arise from the kidney. So he made that interesting observation, okay, and that was in the 17th century. Then we come to the next group of people, who's Mogagni, and this was about 200 years later, was able to establish the idea that the disease may arise from some type of what do you call it, specific organ. And he and his disciple who was, or student who was William Heberdine, said that dropsy is very rarely an original distemper. Now, in those days, they recognized that even animals could spread disease to man. And of course, looking at the literature, at that time, there was a lot of rabies going around, etc. So people used to get mad with rabies, etc. But he realized that with this condition, it was not something that arose from animals, but rather it was a general symptom of some other disease. And often when you got this condition, it was incurable. So once again, he made the good observation that this condition is pretty chronic, okay? So even at that time, as you can see from this picture here, in order to get rid of the excessive fluid from the body, they started doing paracentesis. Now, I don't know how they did this. There was, of course, no local anesthetic and definitely no general anesthetic at that time. So to introduce this tube into this gentleman here, it must have been quite a bit of pain. And you can see his wife is sitting there and comforting him as the physician drains the fluid out of his abdomen. And that was considered to be something curable. So this condition was known right from BC, and then round about this time in the 17th century, it became known that it was a chronic condition. It arose somewhere in the kidney, and of course the name given to it was dropsy. Then came the 18th century, and here dropsy was defined as being dependent on morbid viscera, and they then moved the idea that this could be due to some type of liver or heart disease. And then what they found that if it was not due to that, then of course the second thing was that it could be due to some type of kidney disease. Okay, so that was the next thing that they found. Okay, and then came the idea that if it was not due to kidney disease, it may be due to some type of general inflammation. So then dropsy became an all-encompassing term for heart disease, which was chronic, liver disease, kidney disease, and some type of general inflammation. And at that time, they started doing some type of venipuncture where the physician will come in and drain this blood, which was responsible for the inflammation in the patient. And by doing this, they felt that you could cure this condition. Now, whether that helped or not, I'm not sure, but that was the treatment at that stage. So from that time onwards, we come now to the late 17th century and the early 18th century and the early 19th century. That means from 1789 to 1858. And along comes a gentleman, Richard Bright. And he was the first one who put together this triad of generalized edema, proteinuria, and kidney disease. And of course, for those of us who have been around for a while, you'll know that the early description of nephrotic syndrome wasn't called nephrotic syndrome. It was known by the eponymous name of Bright's disease. Okay, so the condition for a long time was called Bright's disease. Okay, so this was what nephrotic syndrome was. And then it came the early 19th century where Christensen and John Bostock came onto the scene, and they were colleagues of Bright. And they made the note that when protein was in the urine at its highest, it was lowest in the serum. Okay, so they could measure it, right? And they made this observation. And then, of course, Christensen confirmed these findings in around about 1829. So by 1830, nephrotic syndrome came about, which was eponymously known as Bright disease, as a disease of hypoalbuminemia, excessive protein in the urine, which was mainly albumin, and edema. And they knew that this condition arises from the kidney. And then over the next few years, they noticed that there was lots of lipid abnormalities associated with nephrotic syndrome. And how did they make this out? They knew that when you get nephrotic syndrome, the serum of the patient becomes quite milky, okay? And that's, of course, is the excessive triglycerides and cholesterol in these patients, okay? Which is, of course, well known to us today. Then Virchow introduced the term parenchymatous nephritis. And the reason he introduced that term in the late 19th century was that he wanted to differentiate it from the pathological picture of primarily tubular involvement. Now, I'm not sure why he did this, but it became a bit confusing at that stage. And then around about 1872, there was another physician, Klebs, who coined the term glomerulonephritis. And he did this to describe the exudative glomerular changes that would be seen under the microscope when you did a post-mortem biopsy. Well, not really biopsy, but they looked at the kidneys under the microscope, and they could see that there was some inflammation of the glomerulus. So he made the observation that this was more a glomerular disease, and therefore he called it glomerulonephritis. And it was only in around about 1905 that the term nephrosis was coined by a chap called Muller, who then described it as a non-inflammatory disease of the kidney as a substitute for parenchymatous nephritis, right? And this was to contrast it with a more exudative and inflammatory disease that occurred. So it was only in that late 19th century that people started to note that this really wasn't a disease that was due to some type of infection or something, but that it was a chronic condition and that it was mainly from the glomerulus, and they differentiated from other conditions which caused inflammation in the kidney. Now, what other conditions there were, they don't mention in that literature review. So come the mid-20th century, which is the mid-1900s, where we have introduction of kidney biopsy. And this became the mainstream clinical practice of nephrology from about 1950 to 1960. And of course, with the advent of microscopy, etc., and the description of the different pathological types of nephrotic syndrome, there was a whole new dimension added to the histopathological understanding of this condition. And there was, in 1961, a landmark symposium, which was called the SIBA Foundation Symposium, in which a lady was a French lady called Renée Habib, who presented the different histological forms of nephrotic syndrome that were seen in children. And she then described minimal change disease, focal segmental glomerulosclerosis, and other forms of the nephrotic syndrome, right? So I don't know if anyone knows, but if you attended the IPNA conference in roundabout the late 90s, but in roundabout 96, that was the first conference that I went to, she was actually honored at that conference. She must have been over 80 years old by then, okay? And she is up to today considered the mother of nephrotic syndrome histopathology, because she described the different histopathological types of nephrotic syndrome. And of course, around about the Second World War in 1940s, antibiotics came into play, and that played an important role in treating infections that arose in nephrotic syndrome. Remember, they are very immunocompromised. And of course, with the advent of antibiotics, the mortality rate in these patients reduced drastically from about 2/3. That means about over 60% of patients dying from this condition. The mortality rate came down to about 35%, which is close to 1/3. So that was a dramatic advance in the management of this condition. What about steroids? So steroid hormones were first identified in 1936. And by 1946, cortisone was first prepared by partial synthesis from bile acids. On the other hand, ACTH, which is adenocorticotropic hormone, was extracted from pigs and sheep pituitary glands by isoelectric precipitation. And people started using this to treat nephrotic syndrome in the 1950s. Unfortunately, both adenocorticotropic hormone and cortisone had to be given by injection, okay? And so that was problematic because these people described in the then, I don't know what the journal, New England Journal of Medicine, yeah, by Wilson and Anil, the first dramatic response of patients with nephrotic syndrome to this, what do you call it, these drugs, which is ACTH and cortisone. However, with the advent of steroids, what people noticed that many of these patients responded, and mortality from nephrotic syndrome dramatically decreased from about 35% down to 3%, okay? And so the thing is, this was a major advance in the management of this condition. And up to today, of course, as we know, steroids remains the mainstay of treatment of this condition, okay? And so that's the history of nephrotic syndrome. And so it brings us to the case definition of this condition in pediatrics. So what's the case definition of nephrotic syndrome in pediatrics? Of course, the sine qua non, the absolute prerequisite for the diagnosis of this condition, both I think in adults and children, is that you must have massive proteinuria. Now in pediatrics, it is defined as greater than 40 milligrams per meter squared per hour, and that's the ISKDC definition, or greater than equal to 1 gram per meter squared per day, and that's KDIGO's definition, okay? The problem is in very young children, of course, you cannot measure 24-hour urines accurately unless you catheterize the child, but even then too, you can have urine slipping past the catheter, etc. So it's a major logistical exercise and not without attendant complications. So to get around the problem, we use a more facile method of urine protein estimation, and that is to do the urine protein creatinine ratio on a random spot urine sample. Now, the textbooks always say that you have to collect the early morning specimen, and there's good reason for that because they're trying to prevent orthostatic proteinuria. But the problem is in young children, it's very hard for the mother to get the first specimen of urine. So we usually collect a random specimen of urine. And if the protein creatinine ratio measured in milligrams per deciliter of protein over milligram per deciliter of creatinine is greater than 2, then that is defined as massive proteinuria. Anything less than 0.5 is, 0.2 is considered to be normal. From 0.2 to 0.5 is mild. Above 0.5 to 0.19 is moderate, and of course, above 2 is severe. Or most often the labs measure it as milligrams of protein per millimole of creatinine in the urine, and in that case, any value greater than 200 is considered to be massive proteinuria. Now, those are quantitative assessments of protein. Of course, you have to do that in the laboratory. But in a clinic setting or in a district hospital, etc., or clinic, you might not have access to a lab readily, or if you do have access to it, the result turnaround time may not be quick enough for you to commence treatment. So the most facile way, the easiest and simplest and cheapest way to measure proteinuria will be, of course, by urinary dipstick analysis. Okay. Now, on urinary dipstick analysis, anything greater than 3+, that means 3 pluses or 4 pluses of proteinuria is considered to be massive or nephrotic range proteinuria, because that equates to more than 40 milligrams per meter squared per hour. Now, remember on dipsticks, if you look at the urine dipsticks, you'll notice that those pluses, which are the qualitative assessment of proteinuria, is the one measurement, but each one of those pluses of protein, that means 0, trace, 1+, 2+, 3+, and 4+, stands for a range of proteinuria. Okay. And if anyone wants to know the ranges, I can email it to you. But basically, if you look at 3 pluses proteinuria, it equates to between 300 to 999 milligrams per deciliter of protein. And 4 pluses is 1,000 above. Okay. So you can understand that is quite a massive amount of protein that's lost in the urine. Okay. So I spent a lot of time on this because this is the most important aspect. Now, there's only one state where this definition becomes a problem, and that is in a patient who is so severely nephrotic that they have almost unmeasurable amounts of albumin in their serum, right? So if you look at the lab test, the lab will tell you the serum albumin is 6 or 5. They're just guessing it, okay? Anything below 10, the lab cannot accurately measure it, right? So that's just a thumbs up on the basis to give you some type of figure to say, look, the protein is so low that we just cannot measure it. So when the protein is that low, you understand there's very little protein that can spill into the urine. So if you do a urine dipstick at that time, when the patient is severely nephrotic or has long-standing nephrotic syndrome, right, with a very low serum albumin, you can appreciate that your dipsticks will be negative. Okay. And even if you quantitate the amount of proteinuria, it'll show a value that is less than 200 milligrams per millimole. And given the case definition, which I told you, massive proteinuria was the absolute prerequisite for diagnosing this condition, it will not fit. So how do you get around that problem? And to get around the problem, the easiest and simplest thing to do is to infuse the patient with some albumin. The moment you infuse the patient with albumin and they pass the next urine and you measure it, that dipstick goes from 0 to 4+. Okay, immediately, because you have restored the serum albumin. Okay, so that case definition breaks down in that condition. And the only other time where you have a problem is where the glomerular filtration rate is extremely low. So when the GFR drops to less than, say, 5, and the patient is still passing urine, it may be that not enough protein is getting into the filtrate, okay? And so once again, you have a problem. So those are the two extremes where this definition can be a problem, okay? But other than that, it is still considered the gold standard for the diagnosis of this condition. So that's the, like I said, the sine qua non, the absolute prerequisite for the diagnosis of this condition. As a result of the massive proteinuria that we get, the next thing that happens is you develop hypoalbuminemia. Now, the older definition was less than 25 grams per liter, but I see that the new KDIGO definition, and presently I am working with a group of colleagues drawing up the guidelines for steroid-sensitive nephrotic syndrome. And what we decided to do to keep it consistent, we've now changed it from 25 grams per liter to 30 grams per liter. So that's the new definition, okay? So you might see that slight change, and I'm bringing it to your attention, but this is at the moment what is being used, 25 grams, but that's going to change. And of course, the development of edema. And I'm not going to go into the pathophysiology of edema, etc. I think that's a different topic. But I said plus minus edema. Now, why did I say that? Because even with the new definition, edema, they define it as massive proteinuria and or hyperalbuminemia and edema. So in other words, you require 2 of those 3 in order to make the diagnosis of nephrotic syndrome, okay? Now, why is that the case? Is because the old definition included edema, but we know from practice that in children where you diagnose the relapse very early, edema takes a bit of a while because the albumin has to drop to below 25 milligrams per deciliter or 25 grams per liter, and gradually edema takes on. So you might not pick it up early. So in order not to miss the condition early, we said that edema is not a necessarily prerequisite, right? Also, in patients who are much older, say teenagers, adolescents, etc., because they have large capacitance vessels, they are able to accumulate a lot of fluid and not show edema. So in that case, you might get a relapse, or you might get nephrotic syndrome presenting de novo, and you will not pick it up, right, until much later. So therefore, edema, although it is the third limb of this diagnosis, it is not an absolute prerequisite for diagnosing condition. What else do we see as an accompaniment of this hypoalbuminemia? We see hyperlipidemia, which means that you have a total cholesterol of above 5.1 millimoles per liter, or fasting LDL cholesterol of greater than 4.1 millimoles per liter. So that's an accompaniment. It's not part of the case definition, okay? And then also we see a raised alpha-2 globulin. Now I just put this down out of interest. Nobody does this these days, but I remember when I was a student, one of the favorite questions in exam was to give you a serum protein electrophoretic strip. And what you would find there is a low peak on the albumin, a high peak on the alpha-2 globulin, a low peak on the alpha-1 globulin, and more or less normal immunoglobulin, because those are large molecules, right? And they would ask you, what is the condition being described here? And of course, given the fact that the albumin and pre-albumin are low, and the alpha-2 globulin being a large molecule is not lost in the urine, you would of course diagnose nephrotic syndrome, okay? But nowadays we don't do this test, so I just put it down as a matter of interest. Okay, so that's the case definition of nephrotic syndrome, right? Now, how do we classify this in pediatrics, which is different from maybe what you're using in adults, is that with the pediatrics, we can classify the disease I think also in adults by way of etiology. So in other words, can we find an identifiable cause for this disease? Okay. So example, if it's due to say HIV or due to malignancy, if it's due to say a bee sting, if it's due to drugs, or if it's due to lupus or any other autoimmune conditions. Okay. So that's etiology. So where we find a possible etiology for the condition, right? That's considered to be secondary nephrotics. Every other type where an identifiable cause cannot be found, it is defined as primary nephrotic syndrome. Now, I'm going to come back to this term primary later because that is further subdivided based on genetic analysis. But just park that for a while and look at just etiology. So an identifiable cause results in secondary nephrotic syndrome, and non-identifiable cause is primary nephrotic syndrome. Now, in pediatrics, we also define nephrotic syndrome by way of age, right? And why do we define it by way of age? Because age impacts on treatment, and age also impacts on prognosis of the condition, okay? So what are the definitions that we use here? If a child develops nephrotic syndrome from birth to the first 3 months of life, that is classified on the basis of age as congenital nephrotic syndrome. If a child develops nephrotic syndrome after 3 months of life, but up to 1 year, that is defined as infantile nephrotic syndrome. If a child develops nephrotic syndrome after a year, after the first birthday, right up to about 8 years of age, right? And I see KDIGO now wants to extend that to 10 years, but for present moment, we'll use 8 as a cutoff. That is defined as classical nephrotic syndrome. That's the peak age at which nephrotic syndrome develops, right? And then if we get nephrotic syndrome after 8 years of age, that is defined as late onset nephrotic syndrome. Now, why are we bothering to classify it by age in pediatrics? As I said, it impacts both treatment and prognosis. Congenital nephrotic syndrome tends to usually be a very severe disease unless it is secondary to, say, syphilis or cytomegalovirus or something like that, okay? So it is very severe. Majority of patients who don't have an identifiable cause, which is treatable, progress to chronic kidney failure requiring dialysis and transplant. And the majority of patients in this age group do not respond to steroids or to any other immunosuppression. So in my practice, I do not treat these patients with steroids or any immunosuppressives. There's only, I think, one paper that showed a patient with congenital nephrotic syndrome who responded to cyclosporin or something. But given the fact that this is a very severe disease, the patients are severely immunosuppressed, we don't want to immunosuppress them more, they get overwhelming infections. I do not use any immunosuppression in these patients. We just treat them with angiotensin converting enzyme antagonists and non-steroidals, and wait till they go into failure, and then we start dialysis and plan for transplantation once they are over 10 kilograms. So that's congenital. Infantile has a somewhat muted response to steroids once again. Few of them respond, many do not respond, and like the classical forms of nephrotic syndrome, depending on race, etc., the majority of patients either have minimal change disease or focal segmental glomerulosclerosis. After a year of age to 8 years of age, which is the age of classical nephrotic syndrome, the majority of patients who in my setting will be Indian patients, and I don't know whether you see the same condition, but I'll describe it later. The majority of our Black patients have focal segmental glomerulosclerosis. The majority of our Indian patients have minimal change disease. And those that are Indian tend to respond to steroids, right? Nowadays, I'm seeing an increasing number of Black patients responding to steroids, although the numbers are not so large, but we are seeing it previously. We never saw that. But the majority tend to have focal segmental glomerulosclerosis, right? And that's the ones that are usually steroid resistant, right? After 8 years of age, most of the patients that we see, irrespective of histology, tend to be steroid resistant. Okay, they don't have minimal change disease. So age impacts both treatment and prognosis for this condition. Of course, The clinical classification of the disease is based on steroid responsiveness. And this is perhaps the most important classification, irrespective of age of presentation, irrespective of etiology, well, not etiology so much, and irrespective of histopathology, okay, which is the next form of classification. Because as long as pediatric patients are steroid responsive, I do not biopsy them, and I think the majority of centers do not do biopsies, okay? The only center that I know that does the biopsies in all patients who are nephrotic is Tufts, that's in Boston, but they are doing it because of a research study, okay? But the majority of patients who are steroid responsive have a good prognosis, a good outcome, and they are not a problem. The steroid resistant patients, on the other hand, are the problematic ones, and the majority of them have focal segmental glomerulosclerosis, and now over 50% of them progress to chronic kidney failure, necessitating dialysis and transplant. So that's steroid responsiveness as a classification. Histopathology, we are all familiar with this. The predominant primary forms of nephrotic syndrome in the pediatric age group differ somewhat from those in adults, where they see a lot of minimal change disease, but my colleagues told me that now they are starting to increasing number of patients with focal segmental glomerulosclerosis. So histopathology does impact treatment and prognosis to some extent. However, it is not absolute. We are seeing nowadays quite a few patients who have focal segmental glomerulosclerosis that are steroid sensitive, and they have a very good outcome. On the other hand, we are also seeing patients who have minimal change disease in biopsy, and even on repeat biopsy, they still have minimal change disease, but they are steroid resistant and progressing slowly to chronic kidney failure. So histopathology is another classification, and as opposed to the adults where they see a lot of membranous nephropathy, idiopathic membranous nephropathy in childhood is pretty rare. Okay, we hardly see it, and I think in clinical nephrology I described in our setting only 4 patients, because it's so rare, who had idiopathic membranous nephropathy. However, membranous nephropathy is secondary to other conditions like hepatitis B. At one stage was very common, right, in my setting, right? But nowadays, with the advent of immunization, hepatitis B vaccine, it's almost extinct, right? So we see membranous nephropathy usually secondary to either infections or drugs or malignancy. We don't see idiopathic membranous nephropathy commonly in childhood. And the last classification, the last way to classify the disease is by genetics. Okay, now this is becoming now increasingly used in clinical practice. Unfortunately, to date, genetics is quite expensive. We don't have ready access to it, except that I am able to do it in a few private patients who can afford to pay for it. But I am hoping that with next generation sequencing, etc., that genetics becomes more readily available. I'm not sure how many of you have it in your practice, but we definitely don't have it in our routine clinical setting. But genetics plays a very important role, and I'm going to discuss this a little later, so I won't touch on it now. But just to tell you that when you get primary forms of nephrotic syndrome and you are doing genetic studies on them, then if you find a genetic mutation in those patients, they are called primary nephrotic syndrome. Those that do not have any genetic mutation, those are classified as idiopathic, okay? That is something that Agnes Fogo introduced, and I just carried it forward because I think it's quite a nice description when you have genetic studies available to classify these patients who have primary nephrotic syndrome on the basis of genetics. So that's so much for the classification of the disease, okay? So if you look at primary nephrotic syndrome, it can be divided into those that are steroid sensitive and those that are steroid resistant, okay? So the steroid sensitive forms can form either as infrequent relapses, okay? And that term has been defined by us presently, but you get the more severe forms, which are frequently relapsing or steroid dependent nephrotic syndrome, right? On the other hand, you can get the more severe type of nephrotic syndrome, which is the topic of today, and that is a steroid-resistant nephrotic syndrome. Okay. Of course, if you find an etiology for the nephrotic syndrome, then that's classified as secondary nephrotic syndrome. Now, up to now, I've kind of general overview of nephrotic syndrome in pediatrics, but from now on, I'm going to concentrate on the primary form of steroid-resistant nephrotic syndrome, not the secondary forms, and predominantly the histopathological form of steroid-resistant nephrotic syndrome, as I said, that we are seeing in childhood, is focal segmental glomerulosclerosis. There's some clinical definitions in pediatrics. This is how we define remission and relapse. I think it's different in adults, but as I said, the steroid-sensitive types are divided into those that have infrequent relapses, those that have frequent relapses, and steroid-dependent. But our point of interest is the steroid-resistant. Now, why did I bring this definition up? Because we see two types of steroid resistance in pediatrics, and I'm not sure whether you see it in the adult patients as well. But we see those that have primary steroid resistance. That means from the first time they present with nephrotic syndrome and you treat them with steroids, they do not respond, okay? And those are the patients that are very problematic, okay? Then we see another type of steroid resistance, which is secondary steroid resistance. Now, this is classical in our Indian patients. They present for the first time with nephrotic syndrome. We treat them with steroids, they respond. They come in the next episode, we treat them, and they take a little longer to respond, but they do respond. By the third episode, they may or may not respond, but by the fourth or fifth episode, they just don't respond. So they start off with steroid sensitivity and then progress to steroid resistance, okay? So this is what we call secondary steroid resistance. Now, the good thing about this is that these patients, even if they have on biopsy focal segmental glomerulosclerosis, they have a pretty good course in childhood. Remember, they don't progress to chronic kidney failure quickly. So they get handed over to the adults, but on following them up in the adults, by the time they reach 17, 18, or 20 years of age, a percentage of them, and I'm not sure exactly what percentage, start to develop chronic kidney disease and progress to chronic kidney failure, requiring dialysis and transplants. But definitely in childhood, they have a pretty stable kidney function, and although they have pretty frequent relapses, etc., the majority of them tend to respond to immunosuppressive agents. So this is the predominant type of steroid resistance that we see. This, fortunately for us, is less common, but this is the predominant type that we see in about 50% of our Black patients, and that is a problem because they have rapid progression to chronic kidney failure. The common histopathological forms of nephrotic syndrome that we see, and in my practice, I see predominantly Black patients. The majority have focal segmental glomerulosclerosis. Some of them have mesangial-proliferative glomerulonephritis. Those that have steroid resistance, about 20% have minimal change disease. And in some of them, we've seen that although on the first biopsy, they have minimal change disease, on subsequent biopsy, they end up having focal segmental glomerulosclerosis. Now, whether that is a progression of the disease or whether it's due to a sampling error is a matter of debate, okay? But definitely we've seen that, and I've seen it in my practice as well. And then, of course, very rarely do we see membranous nephropathy. Other types of nephrotic syndrome, we see if they are secondary, but very, very, very uncommonly. And I think I have in my whole practice only 2 cases of patients who have mesangiocapillary disease, which is, or membranous proliferative glomerulonephritis, which of course is seen in adults, particularly dense deposit or this type 2 mesangiocapillary disease. And I must say it is extremely rare in childhood. And I don't know whether others are seeing it or not. If you are, then please let me know. So those, the 2 commonest histopathological forms are still minimal change disease and focal segmental glomerulosclerosis, and some of them have mesangial-proliferative glomerulonephritis. These are the ones which are usually the secondary forms, okay? What about the epidemiology of nephrotic syndrome is one of the most common glomerular disorders, as I said, in childhood, right? The incidence, I don't have the exact incidence in our population because, of course, we don't have registries, etc. But from the USA, etc., is described as being between 2 to 7 per 100,000 population. So it's not that rare, okay? What is interesting is that in Asians, there is about a 3 to 4-fold higher frequency than in Caucasians. And just to tell you a little anecdote, I was invited to India, to the Sanjay Gandhi Postgraduate Institute to give lectures. And I was speaking about hepatitis B associated nephropathy because that was the subject of my PhD. And I told them that in the last 17 years, we've seen about 3,000 patients with nephrotic syndrome. And Ajay Gupta told me, we see that in 1 year. That's how frequent it is in Asians, okay? They have 3 clinics devoted to nephrotic syndrome. So it is very, very common in the Asian population. And of course, there's a strong geographical bias to these patients. Even in our own country, we used to see along the coast a lot of hepatitis B associated membranous nephropathy, but in Johannesburg, etc., they very rarely saw it. So there is a regional bias to what this disease presents with. In Central Africa, for those of you who are from Central Africa, I don't know whether you're still seeing malarial nephropathy. And of course, I know there's a lot of description of cystosomal nephropathy, not hematobium, but cystosomal mansoni and ovale from Egypt. So, you know, the spectrum of the disease varies from region to region, depending on what the epidemiology of infections and other things are that predispose to nephrotic syndrome. And like I said, irrespective of histology, in our Black patients, we have a very high incidence of steroid resistance. And I'll show you this in a short while. So throughout the world, they are showing that the incidence of focal segmental glomerulosclerosis, and remember, majority of patients with FSGS are steroid resistant, is exponentially rising. And you can see this is primary glomerulopathy seen over a 12-year observation period. Okay, this was data from the USA. It was published in American Journal of Kidney Disease. And what they showed that focal segmental glomerulosclerosis, FSGS rates, and to a lesser degree, IgA nephropathy was increasing throughout this period. And this is the graph that is shown. You can see all other forms of nephrotic, histopathological forms of nephrotic syndrome are pretty stable except for IgA nephropathy. But FSGS has just taken off, okay? So this was very interesting. And if it happens in the United States, can it happen anywhere else? And the answer is yes. So we looked at our primary nephrotic syndromes at Inkosi Albert Luthuli Central Hospital, which is a central referral hospital for all patients with complex kidney disease. And I see practically every nephrotic in my province, which is KwaZulu-Natal, okay? And what I did was ask one of my students for his master's to do a retrospective review of patients who are 1 to 14 years, because we transfer them after 14 years to the adult unit. To look at the primary nephrotics, and he looked at it over a 16-year period. That means 2003 to 2018, because this was a time that we opened up the renal unit at Inkosi Albert Luthuli Hospital. And what was good is that all the data that we have is based on an electronic system, right? It's captured electronically. So he was able to do a very accurate analysis of patients with nephrotic syndrome. He pulled out all the primary nephrotic syndromes, and we had 231 children in this group, right? Of these 121, 52.4% were males and 110 were females, okay? Giving us a ratio of 1.1:1. So more or less equal number of males and females. And what did we find when we did the analysis? And I'm not going to go through the whole thing, but just highlight the key findings which are pertinent to steroid-resistant nephrotic syndrome. We found that the burden of steroid-resistant nephrotic syndrome increased substantially from 30.5%, which I had reported previously around about 97, to 67.1% in the present study. So there was more than a 2-fold increase in the incidence of steroid-resistant nephrotic syndrome. This increased burden of steroid-resistant nephrotic syndrome was mirrored by an increase in children with focal segmental glomerulosclerosis, not surprising, because that's the commonest histopathological form we see. And what was interesting was a concomitant decline in the incidence of minimal change disease from 13.9%, which I had reported in 97, from 30.8%, which I had reported in 97, to 13.9%. So there was a 2-fold increase in the incidence of steroid-resistant nephrotic syndrome, together with the histopathological form being FSGS, and there was a twofold decrease in the incidence of minimal change disease, right? And this was both in our Indian and Black patients, okay? So you can see that the incidence of steroid-resistant nephrotic syndrome over the years has exponentially increased. We found focal segmental glomerulosclerosis in 70.1% of children who had primary nephrotic syndrome in this study. And this was much higher, as I said, than figures reported previously. In 1976, when Miriam Adhikari reported the incidence of nephrotic syndrome, FSGS was only 3.7%. The majority had minimal change disease, right? In 1981, when she published her thesis, the incidence was about the same, 3.9%. In 1997, steroid-resistant FSGS was about 25%. The other forms of resistance were mesangial proliferative disease and some membranous nephropathy. But once again, there's a rising incidence. So you can see, from being a very marginal therapeutic issue in our center, FSGS has now become the single and most common histopathological finding in our children with primary nephrotic syndrome. And being steroid resistant, of course, it poses a major management problem. So steroid-resistant nephrotic syndrome has really increased in all settings, and I'm sure many of you will have the same experience, right? We can discuss it later. So what's the pathogenesis of this disease? Now, once again, as I said, this is a whole lecture on its own, so I'm just going to highlight the key findings in the pathogenesis. The hallmark of nephrotic syndrome, both in steroid-sensitive or steroid-resistant nephrotic syndrome, is that there is, on electron microscopy, you'll find complete effacement of the podocyte with loss of normal architecture of the glomerulus. And because of this loss of normal architecture, due to factors that I'll describe just now, you have massive proteinuria developing. So what are the factors that lead to the podocyte effacement? There are three important factors, okay? One is the immune-mediated factors, the other is systemic circulating factors, and the third one are genetic factors, okay? So these are the three main factors, right? Apart from many other things that are there, but these are the three main factors that lead to podocyte effacement, and with podocyte effacement and loss of architecture of the glomerulus, you get proteinuria developing. So let's discuss immune-mediated factors. What you find that in nephrotic syndrome, there's dysregulation of the immune system, and predominantly it is of T lymphocytes, although the humoral system is also affected. So what's our evidence to show that T lymphocytes are dysregulated in this condition? Well, the first thing is that all these patients, okay, whether they are resistant or steroid resistant or steroid sensitive, have some response to immunosuppression. Some may not respond at all, but many of the nephrotics respond to immunosuppressive agents. So immunosuppressive agents mainly act on the T cells. So obviously T cells are involved. There's spontaneous remission of the steroid sensitive forms when patients develop measles, right? And we don't see measles nowadays because of the immunization, but when I was a medical student, before immunization for measles came out, we used to see a lot of measles. And interestingly enough, if a patient in nephrotic syndrome developed measles, they went into spontaneous remission. Okay, so this is something that I can tell you really happens. So once again, measles is T cell mediated, so we know there's T cell dysregulation. Also, nephrotic syndrome develops in patients who have Hodgkin's disease, but once you treat them with chemotherapy, with immunosuppressive agents, and the Hodgkin's disease improves, the nephrotic syndrome disappears. So that's another thing that tells us that this is due to some immune-mediated factor, particularly T cells. And lastly, but not least, nephrotic syndrome often develops following allergic reactions. And of course, allergic reactions are T cell mediated. Okay, so we got a lot of supporting evidence that there is T cell dysregulation in this condition. With more modern immunological techniques, we've noticed that there is an increase in podocyte B7-1 expression. And of course, with this, you have development of proteinuria. Now, I'm not going to go into the details of this because I think that's beyond the scope of this lecture, right? So those are immune factors that lead to the development of nephrotic syndrome. But we also know that besides immune factors, there may be circulating factors that may lead to development of nephrotic syndrome. Now, how do we know this? Well, the first bit of evidence comes from the fact that when you take serum from patients who have FSGS and you inject them into glomeruli, either in a petri dish or in a preclinical setting, then those glomeruli start to leak protein. Okay, so proteinuria develops. So there's something in the serum of these patients which damages the glomerulus and leads to proteinuria. We also know that when you transplant patients with FSGS, you can get recurrence of the disease in about 25% of these patients. Okay. But what is interesting is that when you get recurrence of FSGS in these patients, you can treat them by immunoadsorption. Okay. And this results in regression of the FSGS in the transplanted kidney in some patients, not all. Okay. So that's another bit of supporting evidence that there may be some circulating factor that's involved in the development of nephrotic syndrome, particularly steroid-resistant nephrotic. And then lastly, if you have a mother with FSGS and you take her serum and inject it into a glomerulus, then that glomerulus develops proteinuria. Okay, so that's another bit of evidence that there is some circulating factor that's involved in the development of this condition. So what are some of the candidates that are likely to be the circulating factor? The first one that was proposed was heparinase, right? Then there's hemopexin. Both of these were studied quite extensively, and one of my friends who's late now, Professor Mandel, he did quite a bit of work on heparinase, and he showed that if you have heparinase injected into the glomeruli, they've developed proteinuria. If you block it using heparinase blockers, etc., or you use knockout mice, etc., then these patients have abrogation of proteinuria. Okay, so heparinase is one of the candidate circulating factors. Hemopexin is the other one. Angiotensin like 4, I am not very familiar with this because I haven't studied it extensively, but in the literature it is listed as one of the candidates. The other one which is particular interest to me is cardiolipin-like circulating factor type 1. Okay. Now, this is very interesting because this is a factor that is expressed in patients with FSGS, but the gene expression is upregulated quite a bit in patients who have recurrence of FSGS in the transplanted kidney. Okay, and so this is one of the candidate factors that we suspect are one of the circulating factors leading to the pathogenesis of FSGS. And of course, we know FSGS predominantly is steroid resistant. And then a much studied factor is soluble urokinase plasminogen activating receptor. And SUPA is another circulating factor that is upregulated when you have recurrence of FSGS in the transplanted kidney. And there's been a lot of work done in SUPA. Unfortunately, it has been shown that although it's upregulated, etc., suppressing SUPA does not lead completely to abrogation or disappearance of proteinuria. So at the moment, it's starting to lose its glitter. So SUPA is not studied extensively anymore. And so what we've done is we've concentrated our efforts now on cardiolipin-like cytokine factor, and we are hoping to show in a study that this factor is going to be upregulated in patients with steroid-resistant nephrotic syndrome, and hopefully will help us differentiate the two. That means there's resistance from the sensitive type. And the last one is genetic factors. Now, once again, this is a whole lecture on its own, right? So we've done a lot of studies on genetics, but I'm not going to go into that in detail. Just to tell you that there's more than 70 monogenic causes of steroid-resistant nephrotic syndrome. Stroke, FSGS, because of course that's the commonest form of steroid-resistant nephrotic syndrome. Now, identifying genetic causes in steroid-resistant nephrotic syndrome early in the course of the disease is important. Now, why is it important to do that? notwithstanding the fact that this is a very costly exercise and not available to all of us, okay? Well, the first thing is that identifying a genetic mutation allows you for discontinuation of immunosuppressive agents, and I'll show you why in a moment. It aids in transplant management. We know that based on published literature, if you have mutations of candidate genes, particularly like NPHS2 or ACE gene or PCL421, etc., then once you have this genetic mutation, the risk of recurrence of FSGS in the transplanted kidney is pretty low, okay? And of course, it is very important that you pick this up because being a monogenic form of nephrotic syndrome, it is autosomally recessive in the majority of cases, particularly in the sporadic type. And so you can provide genetic counseling to the mother because there's a 1 in 25 chance that her next child may also have that particular gene, okay? So you can counsel the mother and say that, look, if your fetus has this particular mutation and the child does develop nephrotic syndrome, the problem is that they have a higher risk of having steroid-resistant nephrotic syndrome, which is going to be unresponsive to immunosuppressive therapy. Therefore, the child is likely to progress to chronic kidney failure requiring dialysis and transplantation earlier. However, the upside is that if they do get transplanted, the risk of recurrence is pretty low. So it's a double-edged sword, okay? On the one hand, it confers steroid resistance, confers resistance to almost all immunosuppressive therapy with rapid progression to chronic kidney failure. But on the other side, when you transplant the patient, the risk of recurrence is very low. And so you can tailor appropriate treatment. Now, in some patients, you have mutations in mitochondrial genes that are involved in the biosynthesis of Q enzyme 10. And of course, if you find this, then you can use Q enzyme 10 replacement therapy, okay? And then these patients will respond. But this makes up less than 1% of familial cases of steroid-resistant nephrotic syndrome. In my own practice, I've never seen this, okay? But then, and we don't test very commonly for these genes. So it does have, in a very small percentage of patients, some therapeutic implications. Interesting enough, the likelihood of defining a monogenic cause of nephrotic syndrome decreases with age. So if you have congenital nephrotic syndrome, you've got a 70 to 80% chance of finding a mutation. That drops to 60% in the infantile type. By the time you reach the classical form of nephrotic syndrome, it's only 20 to 30%. And after about 8 years of age, it's only 11%. So the risk decreases with increasing age, right? So you don't find a genetic cause as the child gets older and presenting for the first time. These are some of the common genes that's associated, NPHS1 and NPHS2 being the most commonly studied gene. NPHS1 codes for the protein nephrin, while NPHS2 is a podosin gene, okay? I'm not going to go into details of that because as it is, we are running short of time. Can I carry on for another few minutes, Lloyd? Just about finishing, right?
Yes, yes, right? Thank you. Yes, sure.
Okay, thanks. So we did a study looking at NPHS2 mutations, and we isolated the V260E gene, okay? And this was in our patients with steroid-resistant nephrotic syndrome. I'm not going to present all the things. You can read it up because we're running short of time. But what we showed that if you have this mutation, right, then it was interesting that these patients were found in about 1/3 of our Black patients only. None of our Indian patients had this mutation. Okay, and we studied both Indian and Black patients. Right? 33 Indian patients, 31 Black patients. So only 1/3 of the Black patients had this mutation, and they have a very high risk of steroid resistance. And all patients that had these mutations were unresponsive to any form of immunosuppression, whether it be steroids, CNIs, mycophenolate, anything. They were all totally resistant. So finding this mutation is very important because in 1/3 of children, if you do find this mutation, you can spare them the risk of kidney biopsy and the ineffective steroid treatment and other immunosuppression. You can tell the parent that, look, your child has this mutation, it is likely that it's almost 100% that this child is not going to respond to steroids. So there's no point in giving this child steroid. But over and above that, even other forms of immunosuppression are not necessary. You can spare the child a lot of side effects from treatment that is quite potent. And so we think that this will have a major impact once this becomes available in the clinical setting. So just to finish off then, what about management of this condition? Now, when it comes to management of nephrotic syndrome per se, even steroid-resistant nephrotic syndrome, there's a couple of things to deal with. The first and foremost is proteinuria. You want to decrease proteinuria because of course, proteinuria is toxic to the kidneys. Whereas being toxic to the kidneys, you can lead to kidney damage, and that leads to azotemia and chronic kidney failure requiring dialysis and transplant. As part of the chronic renal failure, you get oliguria, and of course you get hypertension, and with hypertension and its attendant complications, you can get retinopathy leading to blood vision. Okay, so it's very important for you to treat nephrotic syndrome because you want to prevent the progression to chronic kidney failure and its attendant complications. So how do you manage these patients? If you look at the KDIGO guidelines, steroid-resistant nephrotic syndrome is, of course, one of the most important indications for kidney biopsy, right? So that's very important, okay? And in our setting, all patients with steroid-resistant nephrotic syndrome are biopsied. The KDIGO recommendation says that if you have a patient presenting for nephrotic syndrome for the first time in childhood, if they don't respond to steroids by 4 to 6 weeks, you start them on a RAS inhibitor, which is either a converting angiotensin converting enzyme inhibitor or a receptor blocker. We commonly use the first because it's cheaper. Then in some centers, they use methylprednisolone as additional therapy. We don't often do that, right? But they wait to give the patient 3 doses of methylprednisolone before they can diagnose steroid resistance. And of course, once you diagnose steroid resistance, if genetic testing is available, this should be undertaken. Okay, so once you got a monogenic mutation that you find, you can counsel the mother and say, look, this child is very unlikely to respond to steroids or other immunosuppression, so we're not going to go down that route. Okay, we should then treat them conservatively with either an ACE or an ARB. The KDIGO recommendation is that in all patients who have steroid-resistant nephrotic syndrome, you should use a calcineurin inhibitor as initial second-line therapy. Okay, now this once again depends on availability and cost. Okay, so I don't know what the availability is in other countries, but definitely in our setting, this is what we recommend, and we have this available, right? And then, of course, in patients who have a genetic mutation, they will not respond, but those without a genetic mutation, the CNIs will give you a response in between 60 to 80% of patients, which is very, very good, okay, for the disease that is so resistant. So this is what we do. We don't have genetic testing routinely. I did that as a research study. So, in our patients where we excluded secondary forms of nephrotic syndrome and we have steroid resistance, we routinely treat them with a calcineurin inhibitor, and we get a response rate somewhere in this. What's the supporting recommendation for this? And I'm not going to go to that in detail, but basically from Raj registry studies, which showed that you can get complete remission in about 50% of children, right? And what has been shown that CNIs are somewhat superior to mycophenolate mofetil. Now, there was one study, which was a randomized controlled trial that showed that CNIs were equivalent to mycophenolate mofetil combined with dexamethasone. But this study is somewhat flawed because to get a statistically significant finding, they had to have 500 patients and they only recruited 138. So of course the numbers are low. So I'm not sure how much emphasis you can place on that. But basically it's been shown in 2 large studies, this randomized control trial and the Paediatric registry, that CNIs are superior to MMF in treating steroid-resistant nephrotic syndrome. KDIGO recommends that you do not use cyclophosphamide or rituximab. Now I put that in red because if you then look at the next guideline that they put out, they say that rituximab can be used with steroid-resistant nephrotic syndrome. And I know there's a lot of publications now that show that, you know, in patients who are resistant to CNIs, etc., people are resorting to use of rituximab. However, the response is still somewhat muted. And in settings where rituximab is not available, and even in South Africa, my colleague uses intravenous cyclophosphamide, although KDIGO doesn't recommend this. What about cyclosporin versus tacrolimus? Nephrotoxicity is about the same. With cyclosporin, you get a lot of Dr. Chandra, can you mute your mic, please? We're getting a lot of interference. Gingival hyperplasia and hypertrichosis are much more common with cyclosporin as opposed to tacro. And of course, glucose intolerance is more common with tacro. Therefore, you should avoid in patients who are obese, those that have glucose intolerance with features of early diabetes, or particularly in those where you have concomitant use of steroids in high doses, okay? And having said that, there's no difference in efficacy between cyclosporin or tacrolimus, right? So I think in our setting, we use tacrolimus quite a bit because of the fact that we want to try and avoid these side effects, particularly in female patients, particularly in the adolescent group, because they don't want to be hairy, etc. Okay, so we use tacrolimus as our first line CNI in these patients. MMF, I'm not going to go to detail with this, just to tell you that it is used as a steroid-sparing agent in frequently relapsing and steroid-dependent nephrotic syndrome, but its effects in steroid-resistant nephrotic syndrome is somewhat less than CNIs, so we still use CNIs. However, we use it in patients who have impaired kidney function because it has a more favorable side effect profile with respect to its nephrotoxicity. It's not nephrotoxic. The major side effect with MMF is, of course, leukopenia and GI side effects, okay? And we have much more relapses with MMF control compared to CNIs, both in our setting and in these randomized controlled trials. However, sometimes we use it as add-on treatment. That means in patients who don't respond to CNIs, we add MMF to treatment. However, there's one study that showed that if you use pretty high doses of MMF with an area under the curve of mycophenolic acid of greater than 45 times 10 to the per liter, then this is associated with infrequent relapses. But to reach this dose, you have to exceed the recommended dosage of MMF, and then you start getting quite severe GI side effects. So I'm not sure if we can do this in a practical setting. Of course, as I said, in patients not responding to CNIs, we sometimes add MMF as add-on treatment, and then we get a response in about 20 to 30%. The other agents, as I said, KDIGO says cyclophosphamide should not be recommended except in the settings where other agents are not available. They say rituximab is not effective, but if you look at the flow treatment diagram, which I'll show you just now, rituximab is used in patients who don't respond to CNIs. Other agents are like vincristine, and then you got the biologicals, right? Here, as you see, this is the treatment of steroid-resistant nephrotic syndrome. Based on the KDIGO guidelines, you can see cyclophosphamide is not recommended except when other agents are not available, okay? And rituximab is being used as rescue therapy. So, you know, they're contradicting themselves, okay? First they say it's not recommended, but in the guidelines, they say that rituximab can be used as rescue therapy. What are the new biologicals? There's a whole lot of them coming into the market. I'm not going to go into them in detail, but you got anti-IL-2 antibody inhibitors, abatacept, ACTH, etc. And these are new agents which are presently in clinical trials or have been shown not to be that effective. So I'm not going to go into that in detail. What are the complications of steroid-resistant nephrotic syndrome? The usual, these are all things that we teach the medical students. You know, it's quite a severe disease leading to malnutrition and growth retardation in childhood. Hypertension is a very common complication. Thrombotic complications are very common in this group compared to the steroid-sensitive group. If they are present in severe relapse, they can go into hypovolemic shock. Of course, they are very immunosuppressed because they are losing a whole lot of antibodies, etc. And so they can develop infections, particularly primary peritonitis. And of course, they can get either acute kidney injury or chronic kidney disease progressing to chronic kidney failure. And this, of course, is the most important complication we are trying to prevent. Chronic kidney disease progressing to chronic kidney failure requiring dialysis and transplant. Dyslipidemias, nowadays we treat them with statins in children. KDIGO says over 10 years, but I've used it in those that are over 7 years, and I've had good response. Of course, it's a form of secondary immunodeficiency these patients develop, especially if they are not responding to treatment. And lastly, but not least, remember, we are treating them with a lot of toxic drugs, so they can develop side effects of drug therapy. So I'm going to stop there and tell you that steroid-resistant nephrotic syndrome poses one of the most important challenges for a pediatrician, a pediatric nephrologist. It's one of the most challenging diseases to treat, right? And to date, the expected response to treatment is only in the range of about 20 to 50%, right? And because of this poor response, this presages the need for development of novel treatments for this condition. Right? If you have genetic testing available and you find a monogenic mutation, then you can determine prognosis and long-term outcome. And this is, of course, independent of histopathology, age, or kidney function at first presentation, which are the factors that impact prognosis. Okay. And in view of the continuing uncertainties in the management of the condition, of course, more randomized controlled trials are needed to determine benefits and harms of these novel treatments. And to date, unfortunately, apart from rituximab, none of the other monoclonals have come to light as being the magic bullet for this condition. Ladies and gentlemen, I want to thank you for this condition. I apologize for going over time. We'll start a bit late, but this is a very, very long topic, and I hope I've given you some idea of what steroid-resistant nephrotic syndrome is in childhood, and I'm happy to take any questions. Thank you.
Thank you very much, Dr. Bhimma. That was a wonderful exposition of steroid-resistant nephrotic syndrome, a very important issue because it's very difficult managing these children,
Yes.
and especially that it's children, a very, very important issue. Thank you very much. If there are any questions from the audience, any questions from the audience to Professor Bhimma, please go ahead.
I got Lloyd, I got a few in the chat. Can I just address those, please?
Yes, yes,
so
yes.
Thank you. Dr. Tadila Yahe said, have we any basis to take 4 to 6 weeks steroid treatment before diagnosing steroid-resistant nephrotic syndrome? Yeah, that's a very good question. If you look at nephrotic syndrome in childhood, okay, the majority of patients who are steroid sensitive usually respond between 2 to 4 weeks, okay? And after 4 weeks, you get a small percentage of patients, if you continue them high dose steroid, would respond by 6 weeks. Now, those are based on studies done in the USA and Europe, etc. In our setting, we have a very differential format response. Our Indian patients tend to respond quite rapidly to steroid if they're going to be a steroid responsive, right? And they go into remission within the 2 to 4 week period. Our Black patients, we give them steroids for 6 weeks because the majority of them only start to respond by 4 weeks. And by 6 weeks, we know that if they're not going to respond, they're definitely not going to respond. I have not seen any patient, well, I won't say not ever, but it's very unlikely that after 6 weeks, they're going to respond. So the IPNA, International Pediatric Nephrology Association, now has changed the guidelines from the ISKDC, which is the International Study for Kidney Disease in Childhood, to say that in a patient who's not responded by 4 weeks, extend your steroid treatment for another 2 weeks. And of course, by then, if they don't respond, you diagnose steroid resistance. Now, some centers go a bit further, and what they do is if by 6 weeks they are not responding, they add by 4 weeks the ARBs or the angiotensin converting enzyme inhibitors, and then they give these patients 3 doses of methylprednisolone. Only after that, if they are still not responding, then they diagnose steroid resistance. I hope that answers your question, okay? That's the pediatric definition of steroid resistance. I don't know what it is in adult nephrology. Vincent, your question was, why is there an increasing incidence of steroid-resistant nephrotic syndrome? Okay, there's a couple of answers to this, right? And this was what one of the reviewers asked me when we submitted the paper. One is that, of course, nowadays, we've clearly defined what is steroid resistance, etc. And patients are being picked up and managed much better. So as a result of which, if you pick up patients earlier, you treat them appropriately, you can diagnose it much earlier than patients who are given steroids for a long time. And then somehow someone realizes, oh God, this patient is still not responding after 2 years of treatment. So yes, That's the one thing, right? The technology is improved, availability of treatment has improved, kidney biopsy is becoming more readily available, and that's another reason. But why is FSGS and steroid resistance increasing throughout the world? And the hypothesis is that there's a lot of influence of what we call environmental factors, and especially focal segmental glomerulosclerosis. You know, I told you that you get two types. One is primary and one is secondary. Secondary is where we find an identifiable cause. Primary is where we don't find a cause, but primary can be divided those that are idiopathic, where you don't find a genetic mutation, and those where you find a genetic mutation, so they're just called primary. Now, in those that are idiopathic, etc., FSGS is also increasing because of environmental influences. And obesity, hypertension, you know, lifestyle change, etc., all impact on the development of FSGS. And my colleague, who's I'm collaborating with from the National Institute of Health in the USA, many of you might know him from the HIV literature. His name is Jeffrey Copps. Jeffrey coined the term adaptive FSGS. So it's a type of focal segmental glomerulosclerosis that develops secondary to lifestyle changes, environmental influences, etc., apart from genetics. Okay, so a lot of us are now starting to eat foods that are very high in salt, high in fat, and refined carbohydrates, etc. And so we are seeing a lot of lifestyle diseases coming in. And with that, we are seeing a lot of kidney disease, of which focal segmental glomerulosclerosis is one of them. That is the finding that we have when they develop nephrotic syndrome. So that's maybe one of the reasons why it's developing. However, I still think there are other factors that may play a role. So I'm not sure of that. But that's an interesting question. And we are hoping that in the near future, if we are able to follow up a cohort of patients, we'll be able to answer those questions. Prematurity, for instance, is another factor that's implicated, okay? Right? Many premature babies used to previously just die because of neonatal care. Now they are surviving, but they have a decreased nephron mass. And you have a decreased nephron mass, there's increased stress on the existing nephrons. They develop proteinuria, and the end stage of that is sclerosis, which is either global or focal segmental glomerulosclerosis. So that may be another factor that impacts on it. Okay, so that was Lloyd. I hope, Lloyd, that answers your question. Right?
Thank you very much. Thank you.
How much CAS in the urine help us to distinguish nephrotic syndrome from nephrotic syndrome? Okay, okay. This is a question that I like asking the fellowship candidates and also the undergraduates. What's the difference between glomerulonephritis as opposed to nephrotic syndrome? And the answers I get are pretty surprising. So many students will tell me that in nephrotic syndrome, you do not get hypertension, whereas in nephritis, you get hypertension. Is that true or false? False. In nephrotic syndrome, you do not get blood in the urine, but in glomerulonephritis, you get blood in the urine. Answer to that, true or false? False. In nephrotic syndrome, you get what do you call it? Hypertension. You get patients who have recurrent infections. In glomerulonephritis, you do not get that. True or false? False. Okay. So hematuria, hypertension, CAS in urine, etc., do not differentiate it, right? But what helps you if you do urine microscopy in nephrotic syndrome, because of the high triglyceridemia and cholesterolemia, you might find CAS, which are white cell CAS and fat, that like Maltese, what do you call it? Granuloma. Okay, so you do not find red blood cell CAS like you get in nephrotic syndrome, because red blood cell CAS are pathognomonic of a glomerulonephritis. So CAS will help you to differentiate that. But what is the key difference between nephrotic syndrome and glomerulonephritis? And the only key finding is the degree of proteinuria, right? Because remember, acute post-streptococcal glomerulonephritis, which is the prototype of an acute nephritis, one of the complications is nephrotic syndrome. right? And how do you diagnose nephrotic syndrome? When these patients develop massive proteinuria. So the hallmark of nephrotic syndrome that differentiates it from any condition is the degree of proteinuria. Now, some people divide nephrotic syndrome and nephrotic range proteinuria. Okay, in other words, massive proteinuria above 40 milligrams per meter squared per hour. And what's the differentiating factor is in nephrotic range proteinuria, you just have proteinuria itself and no other manifestations of nephrotic syndrome. Whereas in nephrotic syndrome, you get the edema, you get the hyperlipidemia, and you get the hypoalbuminemia. Okay, so they differentiate the syndrome from just massive proteinuria. So by and large, it is mainly the degree of proteinuria that differentiates the nephrotic syndrome from the glomerulonephritis. But yes, you are right. In nephrotic syndrome, you really get hyperlipidemia. I mean, in glomerulonephritis, you very rarely get hyperlipidemia unless they're going through a nephrotic phase, right? Like you get in post-op nephritis. And also the type of CAS in the urine. In nephrotic syndrome, you do not find red blood cell CAS, but it's a feature of acute glomerulonephritis. So that's what differentiates it, right? I hope that answers that question. Can we make a mention of immunization nephrotic syndrome? Yes, I didn't touch on this, and that's a very important topic that I had slides on it, but I took it off because of the paucity of time. The immunizations in nephrotic syndrome are all the same except for two important caveats. And that is when the patient is on high-dose steroids or other immunosuppressive agents, like we do for every other condition, malignancy or other forms of rheumatological conditions, etc., we do not use live attenuated vaccines. And one of the questions that came up was, what about coronavirus vaccines? And because that's very topical. So I tell my patients that you can take the vaccines routinely, except those that are live, that have a live virus carrier, like the Johnson & Johnson's vaccine and the AstraZeneca vaccine. The Johnson & Johnson vaccine and the AstraZeneca vaccine have adenovirus as the carriers. And so we recommend patients who are in high dose immunosuppression do not take them. What we diagnose what we take as high dose immunosuppression, if they have steroids more than 20 milligrams per day, okay? Or more than 0.5 milligrams per kilogram in a younger child, right? Or if they are on any other second-line immunosuppression. So as long as they are on any second-line immunosuppression or have steroids more than 0.5 milligrams per kilogram or more than 20 milligrams per day, then we recommend they only take vaccines that do not have live attenuated carriers, okay? So no live attenuated vaccines. But all other vaccines are routinely given, right? We routinely ask patients to get immunization against varicella because with nephrotic syndrome, particularly if they get immunosuppression, you can get severe exacerbation of varicella, right? So if the patient is not immunized against varicella and presents with nephrotic syndrome, you might treat him, but please, if he develops any signs of chickenpox or anything, he needs to be aggressively treated, okay? And we recommend that they get varicella immunoglobulin. If you don't have this available, you can use acyclovir, okay? But we do not recommend acyclovir being given as prophylaxis. Pneumococcal vaccine should be given routinely in these patients, and I recommend that they be given every 3 years because, of course, there is a decay in the antibody response of pneumococcus, okay? So we boost them every 3 years with pneumococcal vaccines. With regards to the other childhood vaccines like measles, mumps, rubella, hepatitis B, etc., what I do in my nephrotics is every year we a titer of hepatitis B. If it's less than 10 milligrams, then 10 international units of HPV core antibody, then I will immunize this patient, give them a booster dose. If it's above that, then I don't bother to give them a booster dose, right? Just like how you do in transplant patients. The others, diphtheria, tetanus, etc., if they have had it in childhood, then we don't give them booster doses. We just know that we assume that they are not going to get it again. Measles, especially, also, there's just a single serotype of measles. So once they have been immunized against measles, I don't give them any boosters for that. So the two important ones we pay attention to are pneumococcal and varicella vaccine. And of course, if they have low titers of hepatitis B co-antibody from vaccine, then we will give them a booster dose, right? With regards to coronavirus vaccines, we recommend they only take vaccines which do not have virus as a virus carrier proteins like adenovirus. What about response to vaccines? Literature shows that patients who are immunosuppressed respond very well, but there is a percentage of them that may have a slightly attenuated response to antibody formation. So it is recommended that when these patients come off immunosuppression or when they are the lower doses, they get a booster dose of the vaccine. So that's so much for immunization. Dr. Nikhil, does that answer your question? Are you happy with that?
Yeah, it's not Nick. I think it's a general, the link shows Nick.
Yeah, oh, okay, yeah. Sorry. Yeah, okay. Let's see, WK, I don't know who that is, but any difference between ACE and ARBs when it comes to management of proteinuria? Is there one that's superior to other? I have not noticed this, and there have been some studies that have been done that show that both are equivalent, and there's also been a study to show that if you combine the both, you do. Although one study showed that you had an additive response, the second study showed that there is not much difference. So I use the one that is cheaper, which is the ACE inhibitors, and go to the maximum dose unless the patient develop complications. Now, one of the most irritating, not severe, but most irritating complication of ACE inhibitors is that these children develop a chronic cough. And of course, mom gives them a whole drum full of cough mixture, etc., and they're not going to respond. So if the child develops a chronic cough, and provided they got no other reason for it, like sinusitis or asthma or something, then I swap them from an ACE inhibitor to an ARB, and of course that takes care of the problem. But I have not come across any study, head-to-head study, that shows any major difference between the two. I think both are both equally effective. Vincent, your question was how frequent is APOL1 and FSGS associates in children? I showed you on that last slide on genetics that in the classical form of nephrotic syndrome, we see it in patients who have sporadic mutations in about 30% of Black patients. We haven't seen it in any of our Indian patients. No, sorry, that's NPHS2. APOL1, I haven't seen in any of our FSGS patients. Okay, I think that study, we did it in a subgroup of patients, and then we did it in a larger study, which one of the students is still have to publish. He finished a PhD in about 74 patients, and we found APOL mutation only in one patient. So it is exceedingly rare in our population with regards to sporadic FSGS. So the answer is no, we don't see it very commonly. In our HIV positive patients, yes, we see it, okay? But in children, once again, it is pretty rare. The adults have described a very high frequency of APOL1 mutations in HIV positive patients.
Thank you, thank you.
Dr. Ashad is from Bangladesh, okay, just said informative. Can nephrotic occur together with nephritic and how it can? Yes. The answer is, I just told you that many patients who develop glomerulonephritis, and the classical type is, say, hepatitis B associated membranous nephropathy. They first present with a glomerulonephritis and then progress to nephrotic syndrome. Okay, acute post-streptococcal glomerulonephritis, which is the prototype of glomerulonephritis that we see in our setting, they can progress to nephrotic syndrome as a complication. So yes, the answer is nephritic glomerulonephritis can progress to nephrotic syndrome. Okay, Lloyd, I think I've addressed all the questions in the chat. Sorry, the time is marching on, but if there's any other questions, I'll be happy to do that.